Good morning, everyone. Welcome to today's journal presentation. I will be presenting the first journal of the day. Adjunctive thrombolytics after successful endovascular reperfusion. A systematic review and meta-analysis of randomized control trials conducted by Dohim et al. And was published in Annals of Neurology in July 2025. Coming to the introduction, uh, as we know, endovascular thrombectomy is a standard of care for large vessel occlusion strokes in the anterior circulation, and it is recommended in posterior circulation. uh, suc- uh, we call it successful recanalization like TICI 2B to 3 in around 80% of the patients is achieved, even with endovascular thrombectomy. But despite the high recanalization, uh, we are able to achieve less than 50% good functional outcome at 90 days. Uh, this creating a outcome gap. But why is this paradox? Though we are achieving 80% recanalization, but functional outcome is only less than 50% at 90 days. Good functional outcome. This is due to pre-existing infarct burden, maybe due to heterogeneous clot compositions, collateral circulation quality in each patient, and microvascular injury, post-stroke medical complications. Therefore, the macro recanalization achieved through EVT is not, it cannot be reflected in microvascular reperfusion. What is no reflow phenomenon? It is a disconnect between the intraarterial thrombolysis is is a intraarterial thrombolysis is a which targets residual distal or microvascular thrombi. Histor- Historically, it was used before EVT era for reperfusion. There are two types of IATs, intraarterial thrombolysis. One is adjunct and one is rescue. Adjunct is when the intraarterial thrombolysis is done after successful or near complete recanalization after an EVT. And rescue IAT is intraarterial thrombolysis is when the EVT fails, that is, we fail to achieve recanalization, that is sticky 0 to 2A. That is called when then if then the IAT intraarterial thrombolysis is done, that is called rescue IAT. Here in this these studies are based on adjunct IAT. Potential benefits in combining EVT and endovascular thrombolysis and intraarterial thrombolysis. Uh, the improves tissue perfusion level and enhances cerebral perfusion, and it can translate to the better functional outcomes. A recent survey of 104 neurointerventionalists has opined that 60% of them used intraarterial thrombolysis with endovascular thrombectomy, despite of no consensus or indication or efficacy. 49.4% has called for more evidence, and around 37% supported its utility, and around 13% considered its irrelevant in current times. IAT is commonly used as adjunct or rescue therapy in large vessel occlusion strokes, but benefit after certain because prior meta-analysis showed conflicting results mostly due to their retrospective designs, and did not distinguish between the rescue or adjunct use of intraarterial thrombolysis, and there are mixed successful and unsuccessful reperfusions post EVT, and heterogeneous agents and dosing. Some studies have used alteplase, tenecteplase, urokinase, and GP2B3 inhibitors. So heterogeneous agents and their dosing. And outcomes focusing on angiographic success but not functional recovery. Safety profile also unclear. So even RCTs limited to successful recanalization showed mixed results. So there is a need of RCT-based evidence based meta-analysis focused only on successful EVT patients. The randomized control trials on adjunct IATs, along with the adjunct IIT plus in endovascular thrombectomy, where the patient has successful recanalization, and in them using the intraarterial thrombolysis. There are six RCTs. Choice trial in done in 2022, published in 2022. Place of study is Spain, and post TNK 2025 China, post UK 2025 China. Studied the drug was studied as urokinase. Angel TNK 2025 again in China. Attention IA trial 2024 China. This attention IA was RCT on posterior circulation and the post UK in urokinase. Choice and Pearl are based on alteplase. Rest all studies are on tenecteplase. Coming to brief introduction, brief about these six trials. Choice trial, which is published in 2022. Here the drug was alteplase, and it is an studied on anterior circulation stroke. And here the primary here out of 61 men, 52 women were recruited, finalized, and primary outcome, the good MRS score, the good functional outcome was at 90 days was studied. Alteplase showed 59% improvement in MRS score. 59% population has showed MRS score of 0 to 1, and in control, that is only EVT group without any active intraarterial thrombolysis, showed 40%. This is adjusted risk difference was very significant. It's 18.4 with a significant p-value in this study. Next is a Pearl study. This is another RCT where intraarterial artery after a successful endovascular reperfusion in acute stroke has been studied. Here, 324 patients were randomized, 99 female, and out of this, 99 were female, rest were males. And here in this study, there was a 44.8 the MRS score, the good functional outcome achieved, MRS 0 or 1 achieved at 90 days was 44.8% in the intraarterial alteplase group and 30% in the standard treatment group with a significant p-value. They have also studied symptomatic intracranial hemorrhage within 36 hours and all other any hemorrhage in 36 hours and all-cause mortality within 90 days, which was not which was has no significant p-value. So, but they have a significant improvement in MRS score at 90 days. Good functional outcome. Post TNK, this study is on RCT trial based on tenecteplase, where the primary outcome again MRS good functional outcome at 90 days. It showed in the intervention group it was 49% and in control group it was 44%. But though there is a marginal difference, but the p-value was not significant. This was a negative trial. And Angel TNK trial is based on again tenecteplase. Here the primary outcome is again MRS score of 0 1 at 90 days, and here the in tenecteplase group achieved 40.5% improvement in the MRS score 0 to 90 days, and 26% in the like standard without any intraarterial therapy, only EVT was given. Here the relative risk was 1.44 with significant value. This showed the tenecteplase group has a this adjunct IAT with tenecteplase had a this group had an advantage over the standard EVT group at 90 days, and they had a good functional outcome at 90 days. And next, coming to attention IA trial. This is again based on tenecteplase. Here, the patients included was 2B 50 to 3, and this is a posterior posterior circulation stroke study. Here, tenecteplase was used, and MRS outcome at 90 days. The adjusted risk ratio was 1.36 with insignificant p-value and confidence interval crossing 1. So this was a negative trial. Next, coming to post UK, this is a single study on urokinase, anterior circulation stroke study. The primary outcome studied was survival without disability at 90 days. And here it was 45% in the urokinase group and 40%. The risk unadjusted risk difference was around 5% and adjusted risk ratio was 1.13%, but the p-value was insignificant. So urokinase this study is a negative study. Coming to the study proper, which is adjunctive thrombolytics after successful endovascular reperfusion, systematic review and meta-analysis of randomized control trials. The study aims were to evaluate the efficacy and safety of adjunct IAT after successful EVT using only RCT data. So all this data used was from the randomized control trials only. Both efficacy and safety of the adjunctive IAT uh, was was uh, was the aim of the study. Primary objective was to determine whether this adjunctive IAT after successful AIT had improved functional outcomes. Excellent functional outcomes were achieved or not at 90 days in patients with large vessel occlusion strokes. Secondary objectives were to evaluate the effect of IAT on the functional independence, that is MRS 02 at 90 days. And also to assess the safety outcomes like symptomatic intracranial hemorrhage and 90-day mortality was studied. Also, subgroup analysis was performed based on the stroke location. It is anterior versus posterior circulation strokes, and also reperfusion grade, like TICI 2B to 3 versus 2C3 versus 3. And drug type used, alteplase, tenecteplase. These all subgroup analysis was done to see the significance of each drug or each class of reperfusion and study the difference between anterior and posterior circulation strokes in the outcome. Methods followed were it is a systematic review and a meta-analysis. It included all the only RCTs which are based on only adjunct IAT, not on the rescue. The exclusion was a rescue IAT, and specifically analyzed patients with successful reperfusion only. It's conducted per Cochrane Handbook methodology, and Prisma guidelines were followed. Protocol was registered in the Prospero database. Search strategy used, they have searched for all the databases, mainly PubMed and Cochrane library, and the time frame was from January 2015 to February 2025. The following search terms were used based on the stroke, large vessel occlusion stroke, EVT, thrombectomy patients, and also the drug, intraarterial thrombolysis and drugs names. Additional sources were also used, mainly the International Stroke Conference 2025 conference presentation abstracts and expert consultations. The eligibility criteria and screening. The inclusion criteria are strictly the RCTs were included, and adults more than or equal to 18 years, large vessel occlusion stroke patients, and adjunct IAT, that is after successful EVT. Patients with adjunct IAT are also studies on adjunct IAT are only included. And if there is no control group, it is studies excluded. Observational and non-randomized studies were excluded. If rescue IAT, that is excluded. Each study has been independently reviewed by 2 reviewers, and disagreements were resolved by 2 senior authors, by a senior author. Outcomes were defined as one technical success. Like after EVT, the technical success of the procedure was assessed using the expanded thrombolysis in cerebral infarction (ETK) score, and the successful reperfusion is defined as scores 2B, 2-3 or 2C, 2-3. Here we can see the ETK score. We all know that MTK, this is an ETK expanded score where the 2B has been classified and subclassified. Here we know 0 and 1 is 0 is like no filling downstream territory, though thrombus reduction is there without any reperfusion is ETK 1. ETK is a 2A where reperfusion 1 to 49% of the territory is seen. 2B 50 is like 50 to 66% of reperfusion of the territory. 2B 67 is 67 to 89% of the reperfusion. 2C is 90 to 99% of the reperfusion. And ETK 3 is near like complete or 100% reperfusion. Here we have in this study, like all the RCTs included, have this above 2B50 reperfusion. And the primary outcome were excellent functional outcome at 90 days, MRS 0 to 1. Functional independence at 90, like secondary outcome was functional independence at 90 days, MRS 0 to 2. And the safety outcome studied symptomatic intracranial hemorrhage and 90-day all-cause mortality. Statistical analysis, random effects model is used because because of multiple studies included RCTs, and there will be methodological differences between these trials. So to ensure a conservative and reliable pooled estimate, random in such analysis, random effects model is used. The effect size is reported as odds ratio with 95% confidence interval, and the variance estimation is through restricted maximum likelihood method. Heterogeneity is studied. Heterogeneity is how different the study results from each other. When we are studying the multiple RCTs, each study differ from each other, and if there is much difference within each study, the methodology, the results, studies cannot be comparable. So this heterogeneity should be statistically tested. It is tested by Cochrane's Q test and I-square statistics. Here, I-square is if it is equal to less, if it is like reaching 0, then it is no heterogeneity, and there means the studies are very much comparable based on methodology and all other things for the methods followed in the study. If it is greater than 50, it is called moderate to high heterogeneity. Subgroup analysis is done based on the IAT type and Tiki score at randomization, prior IV thrombosis is done or not, and occlusion location, that stroke location also. Leave one out sensitivity analysis is done. This is done when multiple studies are included. Each, each study is removed and analysis is done, so that we can see which study is if any outlier is there for particular effect that can be identified. So this is all the analysis are also conducted using Strata version 17.0. After 3,517 records identified, after removing duplicates and screening, the 6 RCTs were included. At the time of this meta-analysis, four RCTs were published. Choice, post TNK, post UK, and attention IA trials were published. But 2 trials, Angel TNK and Pearl, were presented. The results were presented in International Stroke Conference 2025. This IC stroke conference 2025. These 2 were presented that, but at that time they were not published, but they are published now. But the data was already presented at that time. So another trial, date trial, it's not it's a efficacy trial. It's a safety trial, not efficacy is not studied. So it's a phase 1B and 2A study where adjunctive tenecteplase after successful EVT was studied. Primary focus in this study was safety, that is symptomatic intracranial hemorrhage within 24 hours of adjunct IIT. This is excluded from primary efficacy analysis, but part 2 is included in secondary analysis to explore the efficacy. This is date trial is included only in secondary analysis for efficacy. Study characteristics, the population was, as you know, acute ischemic stroke with large vessel occlusion were included, and the patients are presenting with 24 hours of lost known well were included, and reperfusion achieved ETK scores or equal to or more than 2B50 are included, and the baseline characteristics were median age around 65.8 to 72 years. And most of the RCTs had a predominance of male population. Stroke location, the stroke included were ICA and MCA M1 M2 territory, with M1 M2 vessel, majority of them, and one trial, attention IA trial, was based on posterior circulation, rest all or anterior circulation. Some of the studies were trials were using advanced perfusion imaging like CT perfusion. There's intraarterial thrombolysis regimens and reperfusion. The agents we used were alteplase, tenecteplase, and urokinase. Urokinase already seen it only in post-UK trial. Choice and Pearl trial were used alteplase. Rest of the trials tenecteplase. Reperfusion status before randomization. Uh, like before randomization, the reperfusion status like 2C and 3 only were included in post TNK and post UK trial. So only the near total reperfusion achieved individuals were only recruited in this post TNK and post UK trial. But in all the other four trials, 2B, 50, and 67, along with the 2C and 3 are also included in the trial. Thrombolysis, like IV thrombolysis before EVT, that is a bridging, was allowed in choice, attention IA, and Pearl trial. But other trials, during the recruitment, they didn't allow this bridging thrombolysis. Now come to proper results. Excellent functional outcomes. We were the primary objective of the study. Excellent functional outcome at 90 days. That is MRS 0 to 1. It's shown in a forest plot here. Here we can see the different trials based on the drug and also the overall pooled analysis. Here we can see each box here denotes an RCT, that is, and the size of box represents the weightage of the RCT trial. And here this is a pooled analysis of the of those trials. This rhombus shows the pooled analysis. And here we can see overall, when we see the overall, it's a functional outcome at 90 days when we compare all the trials, that is pooled analysis of adjunct IIT. It showed 1.47 odds ratio with confidence interval 1.21 to 1.80. And here heterogeneity can be seen as 0.01 and significant significant p value. So it showed the functional outcome at 90 days was very much significant, with 47% higher odds of excellent recovery compared to the non-IAT group, that is only EVT group. And when we compare the subgroup analysis also, like based on individual drug, now we have seen that overall pooled analysis has shown a significance, difference between the intervention group and control group. Even with the subgroup analysis, alteplase, tenecteplase, and urokinase, here we can see the odds ratio 1.94 with a significant p-value. The alteplase, among all this, alteplase has showed most significant improved in outcomes. Odds ratio of 1.94 with low heterogeneity among these two trials. So choice and Pearl, and with significant p-value. It showed an excellent functional outcome at 90 days. And with the tenecteplase also, the odds ratio was less than alteplase, but it is also significant, 1.43 with significant p-value. So even tenecteplase has showed a excellent functional outcome at 90 days. But urokinase, it was statistically it was not significant. So overall, IIT has shown significant functional outcome at 90 days, MRS 0 to 1, and also individually alteplase and tenecteplase. In that, alteplase has more efficacy compared to the tenecteplase. Subgroup analysis by stroke location. They have compared by, is there any difference in by stroke location on the functional outcome? This anterior circulation stroke and posterior circulation stroke. There are significant improved excellent functional odds ratio was 1.48 individually. And pooled analysis also showed 1.47 odds ratio and with significant p-value. So even with the stroke location, either of the stroke location has showed improved this functional outcomes. But separately, if you see posterior circulation stroke, though odds ratio is 1.51, the p-value is 0.18. So it is not statistically significant. Subgroup analysis by trial reperfusion criteria. Here they have studied different reperfusions like TICI 2B 50 to 3. This This was done, showed a significant, statistically significant subgroup. Means the effect of IIT was seen in this 2B50. This attention IA trial was a posterior circulation study. Even including that study showed significant results. But even after excluding the study, means after excluding studying only anterior circulation, also had a significant uh, efficacy. And trials, if restricted to 2C3, only like completely near reperfusion or complete reperfusion, had no significant statistical benefit. Even with like Tiki 3, only Tiki 3 also, were based on only two RCTs. We already know post UK and post TNK only recruited only Tiki 3, Tiki 3 achieved patients. There also the results were insignificant. So from this we can see that only a patient when 2B50, that when they're 50 to 66% or 66 to 90% reperfusion patient had better benefit than the total reperfusion achieved patients with the when we use IAT. Coming to functional independence at 90 days, MRS 0 to 2. Uh, though there was excellent functional outcomes, MRS 0 1 to 1, but this adjunct IAT did not show significant improve on overall functional independence at independence at 90 days. This was the statistically insignificant. Even the other sensitivity analysis has reproduced the same results. Even after excluding this international stroke 22 to 25 trials, and leave one out analysis also has showed that functional independence at 90 days was not significantly improved with this adjunct IAT. Uh, this functional independence at 90 days when subgroup analysis based on the individual drug also has not shown the many benefit. Based on the stroke location also, functional independence, uh, even in anterior circulation stroke, the functional independence has no difference, not significant. Symptomatic intracranial hemorrhage was studied. Safety. Pooled odds ratio showed only 1.5, 1.15 with significant p-value, denoting that there was no increased risk of symptomatic intracranial hemorrhage. Even with individual individual drugs were also tested, but the p-value was not significant, and the odds ratio was close to 1. Subgroup analysis also showed with ICH symptomatic, as I told, it's no significant increase in risk of intracranial hemorrhage in adjunct ICH. Even stroke look based on anterior circulation stroke or posterior circulation stroke, there is no increased risk of intracranial hemorrhage post adjunct IAT. Mortality, subgroup mortality and analysis of mortality also at 90 days was studied. That no individual alteplase, tenecteplase, or urokinase, this p-values were not significant, denoting that no drug has increased any 90-day mortality. Overall study also showed was p-value was 0.81 with odds ratio of 1. So that 90-day mortality nor increased or decreased with this overall pooled analysis also, and also with individual drugs. Same with stroke location. The mortality was at 90 days. There was no significant difference between the anterior circulation or posterior circulation stroke. Here we can see the odds ratios achieving 1. Here also 1. Here also 1 with insignificant p-values. Coming to discussion, adjunctive IAT after successful EVT improves excellent functional outcome. MRS achieving MRS 0 1 to 90 days. Benefits mainly seen in anterior circulation stroke, and posterior circulation benefit remains uncertain because maybe due to only once RCT was one RCT was included, which was of posterior circulation, and there was no increase in symptomatic intracranial hemorrhage and no increase or decrease in 90-day mortality. And EVT restores large vessel flow only, and microvascular obstruction may persist even after EVT. This is called no reflow phenomenon. No reflow occurs around 30% even after successfully reperfused patients, and it is responsible for worst outcomes in these patients. And here, where the IAT may be helpful to dissolve this distal microthrombi, improve the microcirculatory perfusion, enhance the tissue level recovery, and improves the outcome. With the adjunct IIT, we have seen in this meta-analysis, we have seen that TK 2B3 patients had a possible macrocirculatory improvement, which was not seen in that patients with TK 2C or 3, that is a near already achieved near perfusion or complete reperfusion in the EVTs. Didn't show much benefit, which was not statistically significant. And there's no safety differences by drug, whichever the type, alteplase, tenecteplase, or uniplase. There was no increase in intracranial hemorrhage or stroke location. Also, did not affect the safety outcomes. Benefit over in posterior circulation strokes remain uncertain due to limited data. Limitations of this meta-analysis were, though there are 6 RCTs, in such kind of studies, we need more number of RCTs for a better statistically significant outcomes data. And variability in thrombolytic agents of these studies and dosing also varied among these RCTs. And some of the data derived in this meta-analysis at that time was conference presentations data and potentially underpowering from clinical endpoints. And predominantly anterior circulation data is used, and this cannot be limiting the generalizability of this results to posterior circulation strokes. So future research is needed on posterior circulation stroke and patients exclusively on the TK3 patients, and optimal drug and dose should be also be studied. And the role of IAT in distal and medium vessel occlusions also should be studied. This meta-analysis was done on a recent like 2022 to 25 RCTs, which are most of conducted from China, and one in Spain. All that 3 drugs were studied. Urokinase, which was already negative in trial. So now our interest was alteplase and this tenecteplase. Meta-analysis showed that 90 days good, excellent functional outcome, MRS 0 to 1 has achieved in the even in the pooled analysis and also in the individual drugs also, alteplase and tenecteplase. But it was not in functional independence at 90 days was not significant. And this is based on this is functional primary or secondary objective. Safety wise, there was no increased symptomatic intracranial hemorrhage. Even over and above EVT, we are using intraarterial thrombolysis. Even with individual drugs, there was no. So the efficacy wise, this safety wise, no increase. And mortality also, there is no increase or decrease in mortality. But these most of the studies were from anterior circulation stroke. Posterior circulation stroke RCTs should be need of studying posterior circulation stroke. And also this TK3 only this main results are shown on patients uh, with 60, those who have achieved 60 above 50% till 90%, 99% till 90% reperfusion patients only. Above 90 and near total reperfusion, the results were not significant because to tell that near complete. Yes. No safety concerns. Uh, yes. Already neutral. Alteplase has a better. Uh, with this, maybe, uh, can we already people already neurointerventions are already using, but maybe this can be tried in two groups with 2B, like 250 and 2B, like 60 below 90%, not in the other groups, because the other groups has not statistically shown. Can be tried because safety also has been established. Safety has been, so we can try uh, and needs to be done because future studies should become so. Which one? Either. Either.
Good morning, everybody. I'll be presenting the second journal of today. That is an effect of thymectomy on late onset myasthenia gravis. That is a multicenter longitudinal retrospective study. Moderator for today is Ashish, sir. So I'll be dealing under these headings. That is introduction, why thymectomy should be done in myasthenia gravis, what are the indication of thymectomy, the landmark MGTX trial, and regarding my article and the strengths and limitations of my article and take home message. So introduction. So myasthenia gravis is the most common neuromuscular junction autoimmune disorder. It is mainly because of production of autoantibodies against receptors in the postsynaptic membranes. Most commonly, it is because of acetylcholine receptor antibody mediated. Types of myasthenia gravis is juvenile myasthenia gravis, early onset myasthenia gravis, and late onset myasthenia gravis. Early onset is less than 50 years of age, whereas late onset is more than 50 years of age, and juvenile is less than 16 years of age. So the autoantibodies present in myasthenia gravis are acetylcholine receptor antibody, which is divided into ocular myasthenia gravis and generalized myasthenia gravis, and early onset and late onset myasthenia gravis, and thymoma associated myasthenia gravis. And other antibodies are MuSK antibody associated myasthenia gravis, which is about 7 to 10% of all myasthenia gravis will be MuSK antibody associated, and they predominantly affect the cranial and bulbar muscles with predominant respiratory involvement, early respiratory involvement. And LRP associated myasthenia gravis are the another autoantibody. And there is triple seronegative myasthenia gravis if all three antibodies are negative. In those myasthenia gravis, autoantibodies found are agrin, titin, ryanodine receptor, alpha subunit of voltage gated potassium channels. So why should we focus on late onset myasthenia gravis? There has been increased incidence of myasthenia gravis in elderly, and immunosenescence that alters the immune behavior. Immunosenescence is mainly as the age progresses, there is changes in the structural and functional activity of the immune system, that is innate and acquired immune system, which can alter the immune behavior. So thereby leading to increase in myasthenia gravis. Then there is higher surgical risk in elderly, and evidence for thymectomy is strong in early onset myasthenia gravis according to the landmark MGTX trial, whereas evidence for late onset myasthenia gravis thymectomy remains controversial in this people. So the role of thymus in early onset myasthenia gravis is mainly because of genetic susceptibility or environmental triggers. There is formation of germinal center. Normally in thymus, there will be no presence of germinal center or B cells that is present in the thymus. Whereas in this early onset myasthenia gravis, there is production of germinal centers and intrathymic lymphoid follicles will be formed, which will produce local production of high affinity anti-acetylcholine receptor antibodies. And also there are thymic myoid cells that are present in the thymus, which mainly express acetylcholine receptors that will be presented to the T cells, naive T cells, and those T cells, those will be are, considered as the self antigen. And regulatory T cell, mainly T cell, there are T regulatory cells that are present, which are mainly involved in the destruction of uh, auto auto uh, autoantigen mediated T cells, which will be escaping from the thymus, will be destroyed by the T regulatory cells. So this T regulatory cell dysfunction can also be involved in thymus early onset myasthenia gravis. So in late onset myasthenia gravis, in early onset myasthenia gravis, it is more of thymic hyperplasia and thymic dysplasia. And whereas in late onset myasthenia gravis, it is more of thymic atrophy. So thymus normally atrophies as the age progresses. That is, it starts from 18 years of age. By 40 years of age, there is almost a replacement of thymic tissue by fibrofatty tissue. And there is autoimmune response element, autoimmune regulator that is present, that is a gene present, which is mainly involved in expression of MHC2. So the MHC2 cells will be expressed by the antigen presenting cells to the T cells in the thymus, which will be recognized as self antigens. Whereas as the age progresses, the thymus involutes and there will be reduced MHC2 expression. Thereby, the self antigens will be less recognized in this. And as the myoid cells reduces, the self antigen, that is acetylcholine receptor, will be reduced, and there will be failure to generate T regulatory cells. In early onset myasthenia gravis, the T regulatory cells are produced, but there is dysfunction in the T regulatory cells. Whereas in late onset myasthenia gravis, because of the thymus involution, there will be reduced production of T regulatory cells. And there are two immunosenescence and inflammaging. So these two are also involved in thymus in late onset myasthenia gravis. That is, immunosenescence is mainly age-related disruption in the structural architecture and functional components of innate and adaptive immune system. As the thymic involution occurs, there is reduced number of naive T cells and increased peripheral oligoclonal growth of memory T cells. Because of this decreased T cell receptor diversity, there is production of autoimmunity. And inflammaging is a chronic low-grade inflammation that is present in this aging population. There is increased interleukin 6, NF alpha, interleukin 1 beta. So these things will mainly maintain this autoimmunity that is going to maintain this autoimmunity because of low-grade inflammation. And this causes activation of latent autoreactive clones that are present, and that leads to increased autoantibody production. So this is the pathogenesis, mainly genetic predisposition or thymic hyperplasia or thyma, certain drugs like penicillamine, all these things, and which causes antigen presentation, that is acetylcholine receptor antibody presentation to naive T cells. So this naive T cells, there will be altered Th1, Th2 balance. There is increased Th17 and reduced T regulatory cells. And there will be, because of inflammaging, there will be increased interleukin 2, interleukin 6, interleukin 17. So all these things causes B cell activation, leading to differentiation of plasma T cells and production of acetylcholine receptor antibodies. So why should we do thymectomy in myasthenia gravis patients? So because of this, it removes the source of all autoreactive T cells and reduces the intrathymic germinal centers and also reduces the autoantibody production. So according to MGTX trial, it has shown that there is a reduced steroid sparing effect after the patient undergoes thymectomy in thymic hyperplasia and early onset myasthenia gravis. And there is also improved long-term remission rates that is present in after thymectomy. So this was the MGTX trial. That was the landmark trial that was published in New England Journal of Medicine in August 11, 2016. So it was a multi-center international rater-blinded randomized trial, which included 126 patients, 18 to 65 years of age, considered non-thymomatous acetylcholine receptor positive generalized myasthenia gravis patient. So disease duration of less than 5 years with MGFA grading of 2 to 4 were included. So what is MGFA grading of 2 to 4 means? MGFA grading 1 means ocular myasthenia gravis. After 2, 3, 4, and 5 are generalized myasthenia gravis. So 2 is generalized, 2 is again classified into 2A and 2B. B is for bulbar involvement and A is for generalized myasthenia gravis. So if 2A, it can also have ocular and bulbar involvement, but 2A will be more of generalized myasthenia gravis and mild amount of bulbar and ocular involvement that will be present. So it will be classified as mild, moderate, and severe until 2A, 2, 3, and 4. And 5 is patients who are intubated requiring mechanical ventilation. So what it means is less than 5 years of age is MGFA grading 2 to 4 means they did not consider ocular myasthenia gravis patients, only considered the generalized myasthenia gravis patients. And they compared the transternal thymectomy plus alternative prednisolone with alternative prednisolone alone. So this thymectomy plus alternative prednisone patients were 60 patients and alternative prednisolone, 66 patients and alternative prednisolone alone were 60 patients were compared out of 126 patients. And qualitative myasthenia gravis score was 6.15 in thymectomy plus prednisolone patients versus 8.99 in alternative prednisolone alone. And the p-value was statistically significant. And the prednisone dose was also reduced in patients who underwent thymectomy along with prednisone. So there was reduction in the prednisone dosage also. So MGTX usually included patients between 18 to 65 years of age, but what does it tell about late onset myasthenia gravis? Although it was not specifically designed for late onset myasthenia gravis, it included patients up to 65 years of age. And the subgroup analysis, that is less than 40 years of age and more than 40 years of age, the benefit was consistent across all age groups. But the only thing was there were very small number of patients with late onset myasthenia gravis more than 50 years of age, and majority of the patients were younger. So it was according to the international consensus guidelines for management of myasthenia gravis. So it included that the indication for thymectomy in myasthenia gravis is mainly in all patients of thymoma. We have to do thymectomy irrespective of the generalized myasthenia ocular myasthenia gravis involvement. And if non-thymomatous patient generalized myasthenia gravis, it was considered age 18 to 50 years was only considered with positive acetylcholine receptor antibodies. And if patient is not having adequate control with symptomatic therapy, then thymectomy may be considered in these patients also with symptomatic therapy if there is inadequate control. So it is not indicated in patients with pure ocular myasthenia gravis and MuSK antibody positive myasthenia gravis, because in MuSK antibody positive myasthenia gravis, there is not much involvement of there is not much thymic hyperplasia that is seen in MuSK positive. Even in other LRP4 positive myasthenia gravis, it is also not indicated. So coming to article proper, my article is effects of thymectomy in late onset myasthenia gravis. It was a multi-center longitudinal retrospective study. It was published in Annals of Neurology in September 2025. So the study objective was mainly to compare in late onset myasthenia gravis patient who underwent thymectomy versus medical management and to evaluate the adverse events. So study design was a multi-center longitudinally retrospective trial. It included patients, took the data from the Chinese National Myasthenia Gravis database from 4 representative hospitals from West China, Jianwu, and Sun Yat-sen's University and Tangdu Hospital were considered. So the inclusion criteria were they considered patients who were diagnosed myasthenia gravis according to 2020 guidelines, and the age of onset they considered was more than 50 years of age with ACRA positive status and MGFA class 2 and above, and without thymoma, either confirmed by post-op pathology or CECT, and 24 months of follow-up from thymectomy was considered. So study design is mainly they compared thymectomy with medical treatment alone. So the basic demographic and clinical data were extracted. There is MG-ADL scores and MGFA classification was done. Classification was taken, and bulbar symptoms, comorbidity, what are the medications they were taking, disease duration, follow-up, outcome, and time to outcome was documented. Medications, if either the patient was taking steroid medications or if the patient was on non-steroidal immunosuppressant drugs like they were on azathioprine, tacrolimus, mycophenolate mofetil, was also taken into consideration. So outcome was graded by MGFA post-intervention status guidelines. So MGFA PIS guidelines mainly considered 8 variables. That is mainly considered the eating, swallowing, breathing, and it also considered other than that, there is ocular involvement and getting up from chair and using his hand for brushing or combing his hair was considered in this. It was graded by MGFA PIS. It was graded in 1, 2, 3. The maximum score out of this 8 was 24 and 0 was normal. So it was graded by MGFA post-intervention status guidelines. The study population were a total of 265 patients were eligible. So from West China, Zhangwu, and Sun Yat-sen University and Tangdu, a total number of myasthenia gravis taken was 1,819, and they excluded patients who were early onset and thymoma, and if only a patient had ocular myasthenia gravis, that is MGFA1, and acetylcholine receptor antibody negative, and follow-up of less than 24 months. So subjects included were total was 265 after exclusion, and thymectomy done out of which thymectomy was done in 55 patients, and only on medical treatment was 210 patients. So they took percentages for categorical variables, and the mean plus or minus standard deviation or median were taken for continuous variables. And chi-square was used to compare categorical variables, and Mann-Whitney test were used for continuous variables. And p-values less than 0.05 was considered significant. They used Kaplan-Meier analysis with long rank test to compare cumulative incidence of response between thymectomy and medical treatment groups. So Frey-adjusted Cox proportional hazard regression was also introduced in these patients. So the baseline characteristics was seen out of 265 patients. The baseline characteristics, mainly the age of onset was different. Mainly because surgeons usually take younger patients with lesser comorbidities for thymectomy when compared to older patients with more comorbidities. So hence the patient onset age was for thymectomy was 56 when compared to 62 in medical treatment. So this was this was significant age difference between these two. Other than that, all other baseline characteristics, including MGFA classification, bulbar symptoms, aging, medications were all not different. So we had to introduce matching. So in these patients, like randomization in randomized control trial, they introduced propensity score matching analysis. This propensity score matching analysis was done mainly to remove the selection bias. So what they did is the probability of the patient receiving treatment based on their baseline characteristics was taken. If the patient is having thymectomy with multiple comorbidities, then those patients were matched with similar patients on the medical treatment also, and those patients were taken into the study to maintain the power of the study. So each thymectomy patients were matched to one or two medical patients with similar propensity score. So they took 9 observation variations. That was gender, onset of age, MG-ADL score, MGFA classification, bulbar symptoms, the oral medication that they were taking, comorbidities, disease duration, and follow-up time. So after this propensity score matching, we got 55 patients with late onset myasthenia gravis with thymectomy, and 110 patients treated with medicine were identified as match cohorts. And to this match cohorts, they applied Cox rank test were applied. So the primary outcome was remission, that is including complete stable remission and pharmacological remission. So complete stable remission means patient is not having any symptoms for about 1 year, not on any medication. That is complete stable remission. Whereas pharmacological remission is when the patient is taking some pharmacological drugs, but still patient is not having any symptoms even after careful examination of the patient. That is complete stable remission and pharmacological remission. Whereas minimal manifestation status is when patient is not complaining of any weakness as such, but patient is having on careful examination by a trained professional, the patient can find some amount of mild weakness, that is called as minimal manifestation status. So this was the primary outcome. This was the response. And time to outcome was the period from the treatment until the minimal manifestation status or better status for obtained. So these two were considered. And also they compared the incidence of adverse events within the 1 month of time. Here that was defined as an unfavorable or unexpected medical occurrence or any worsening of symptoms in patient who received thymectomy, regardless of whether it was directly caused by treatment. So these adverse events were compared with younger population and not in this population. So after the propensity matching, so there was a age difference of about that is 56 in thymectomy and 62 in medical treatment. That was matched to 56 and 56. And the gender and MG-ADL, bulbar symptoms, MGFA are all matched, so that there was no significant difference in the medical treatment and thymectomy group. So after matching, after applying the statistical tools, that they found that there was a higher average treatment effect with significant p-values. That is, thymectomy positively influenced the outcome. And accumulate, that is, patient achieving minimal manifestation status or better status were about 2.3 times more in thymectomy group when compared to medical group alone. So that was the after matching, this was the result. And subgroup analysis they did within the time period, that is on 2 years, 3 years, and 5 years they have considered. So there was in time there was in there is statistically significant difference in 2 years, 3 years, whereas at 5 years there was no statistical significance because because of the data in after 5 years follow-up was lesser when compared to the 2 years, 3 years data. That is why there was lesser p-value. There was no statistical significance. So here, if we see this Kaplan-Meier curve, it shows that in late onset myasthenia gravis, the cumulant event probability, event being the minimal manifestation status or better status, that is higher with patients with thymectomy, whereas in compared to medical treatment. And after 100 months of it becomes same in Kaplan-Meier curve. And outcomes at different time points was also, that is, if you see this graph, there was thymectomy was 45 and medical treatment is 80 in the initial 24 plus or minus 2 months, that is the initial 2 years. As the follow-up increased, there was only 21 thymectomy patients and medical treatment was only 38. So there was no statistical significance. But however, at 2 years and 3 years, the patient achieving remission and minimal manifestation status was significantly higher when compared to medical treatment. And in also at 3 years also there was significant difference between the thymectomy and medical treatment, whereas at 5 years there was not much difference that was seen. So assessment of surgical safety, mainly they compared thymectomy in late onset myasthenia gravis with the younger patients, that is between 40 to 50 years of age, and they only compared the adverse events within the 1 month. So in which 50 of late onset myasthenia gravis was compared with younger onset myasthenia gravis patients. So there was equal incidence of adverse events, that is 32% and 22%, with p-value of 0.286. That was not significant. So there was no significant increase in adverse events in late onset myasthenia gravis compared to the younger 40 to 50 years of age patients with myasthenia gravis. So these were the adverse events that was seen. There was 16 events in more than 50 years of age, and 40 to 50 years there was 11 events. So there was no life-threatening events was seen in 5 in 50 years and 4 in 40 to 50 years of age. That was also no statistical significance that was seen. And other adverse events were also not statistically significant. So the discussion is this retrospective cohort provides evidence supporting that the late onset myasthenia gravis can benefit from thymectomy. Also, it emphasizes that there is no significant post-op complication from that of younger population, that is 40 to 50 years of age. And there were previous 6 studies that was done, which was showing variable rates, that is between 28.6 to 80% difference in the thymectomy when compared to medical management alone. Whereas the landmark trial and other 4 studies also showed better outcome with this thymectomy. The strength of the study was a large late onset myasthenia gravis cohort till date. Is this the only study which is the largest cohort study, and is a multi-center national database, and it is have made it a comparative design because of propensity score matching. After matching, there was comparable data, and comparison with any surgical cohort to look for any adverse events were also done. So adverse event also checked in this study. The limitation of this study is a retrospective study, and there is variability in medical treatment. They have not actually told what was the treatment that we are taking. They are only told that non-steroidal immunosuppressant medications and steroids, but they have not specifically mentioned what medications were, but they were matched after propensity score matching. And the number of surgical patients after 65 years of age is relatively low. So we can't tell after 65 what is the changes that is seen. And because it was only conducted in China, it is not generalizable to the general population. So other similar studies that was done is that is this was done in a European Journal of Neurology in 2025. So in this, they considered 4 electronic databases from September 10, 2024, and 6 studies were considered. But the subgroup analysis showed that there was improvement in myasthenia gravis. They showed that thymectomy potentially effective treatment in late onset myasthenia gravis patients. And effect of thymectomy in late onset myasthenia gravis without thymoma. This was published in Clinical Neurology and Neurosurgery, which included only 34 patients. No, 22 patients with general weakness at entry showed that thymectomized group had a greater clinical remission when compared to only medical management, non-thymectomized group. So it also showed that potentially effective treatment for late onset non-thymomatous patient with mild generalized myasthenia gravis. So the take home message is thymectomy may be considered as an effective therapeutic option for late onset myasthenia gravis, but there is no increased risk of perioperative operative complication in this largest cohort, which is done when compared to younger population. But we have to take this because it is only a retrospective cohort. We can't. We need a randomized control trial in this late onset myasthenia gravis population to confirm that thymectomy will be helpful in these patients. Thank you.
Well presented, Tejas. So this was a multi-center retrospective cohort to assess the benefit of thymectomy in patients with late onset myasthenia gravis. And the study results support thymectomy in late onset myasthenia gravis patients, and the adverse effects were comparable to patients who underwent thymectomy in a younger age group. However, the results should be interpreted with caution here. Firstly, this was a retrospective study. Being a retrospective study, there was a substantial potential for unmeasured confounding factors like the frailty, the cognitive status, comorbidity status, surgical fitness, refractoriness of the disease. And secondly, the patients who were operated for thymectomy were in a notably younger age group of 50 to 65 years, whereas in the medically treated group, there were many patients who were above 65 years, which shows clinician preference to operate younger, fitter patients with late onset myasthenia gravis. So the response rate of 2.4-fold higher response in this group should be interpreted as a hypothesis generating rather than evidence of superiority, and a larger randomized control trials with a longer follow-up duration is required to prove this hypothesis. No, in non-thymomatous group also, if the patients are 18 to 50 years, regardless of the thymoma status on imaging, the international consensus guideline is to operate. Yeah, even if it is yes.
We are ending the session. Thank you.